Hey guys, welcome back. And today we're going to talk about something called the Tennessee technique. Now, I don't know if it has a more formal name, but that's what we're calling it today, and I'm going to copyright it and patent it so that if you use it, maybe I'll get a little bit of royalties. In either case, this tip and trick was shown to me by many a veteran paramedic in the area north of Nashville, Tennessee, back in the day when nasotracheal intubation, as you've already heard, was in very common use. Now, this tip is just a simple modification to the normal blind nasotracheal intubation technique. Now, normally what you would do is you would stick your ear up to the 15mm adapter of the nasotracheal tube and listen for the flow of air as you advance the nasotracheal tube into the trachea. Now, obviously this has several disadvantages. One is you are quite literally at bad breath distance with a very sick patient. This is not ideal. Nobody wants to have their face and mouth next to a patient who may have pneumonia, may have any number of communicable diseases. Secondly, if you have a very loud ambient environment, such as during extrication or in an aircraft or any number of other situations, you are not going to be able to hear and appreciate the subtle airflow that occurs in these situations during the passage of a nasotracheal tube. Thirdly, when your head is down next to the patient's mouth and nose, your sense of situational awareness is compromised. So, by doing this technique, we provide a little safety distance, we give us an opportunity to observe our environment, and this improves the volumes and our ability to appreciate the airflow of air without any other fundamental change. Now, what is this technique? Well, quite simply, you take a single lumen stethoscope, that's a single tube, pull the bell off, so a very cheap stethoscope is ideal, but I've done this with a Littmann also, so it's not a big deal. And then you stick the end of the tube, without the bell, loosely in the end of the endotracheal tube and the 15mm adapter. You don't want to plug it in there, you don't want to wedge it in there, but you want to rest comfortably in there. And then you simply listen to the airflow with your stethoscope as you advance it back. Now, this will make a lot more sense in the next few slides as we show some videos of this. But what you will see, or actually more appropriately what you will hear, will be 4 different volumes of sound. 3 of which are desirable, 1 of which is not. So the 3 desirable sounds are as follows. Loud. As you pass through the nasal pharynx, you will have loud respiratory sounds. As you transition from the nasopharynx into the hypopharynx, it will become louder. And honestly, at this point, it will become quite loud and continue to get loud until you're right outside the trachea. And a common mistake, sometimes people mistake the sounds right outside the trachea for being in the trachea itself. The third sound will be loudest, and this will be as you slide the endotracheal tube into the trachea itself. Now, you'll be able to tell this is different because your ears will actually be able to feel the flow of air. It will be significantly louder on a volume you have not previously experienced. It will be almost confirmation of proper placement. However, if the endotracheal tube actually goes into the esophagus, that will produce the 4th sound. And the 4th sound is a very muffled airflow sound because you'll be in the esophagus, you'll be out of the direct airflow, and you will hear your volumes almost diminish completely, which is a definite sign that you've missed the tube. So you can see that that is also very useful as well. So thank you, and hope you enjoy the videos we've produced.